So the tests we've performed so far are with one particular APTT reagent. I just want to do a couple of tests, just APTTs, on 2 of those samples. And I want to repeat that now with the second APTT reagent. So I'm going to put out some of this to be warming. This one actually contains a fluid phase activator, ellagic acid. So I'm going to replace this to be warming up with the first one. Different APTT reagent. Make sure we've got enough, a little bit more calcium chloride. So I want to retest APTT on some of the patient samples. Let's see what we get. We are compelled to do a control first. It's a different reagent. We need to be sure that this is working appropriately. So we need normal control first. This is a different reagent. It contains a significantly higher phospholipid concentration. It's not the only difference between these 2 reagents. The activator is ellagic acid, the previous one silica. The biggest difference is in the phospholipid concentration. This second reagent, the concentration is around 15 to 20 times higher than the concentration in the first reagent. So if we're dealing with a factor deficiency, the numbers may be slightly different, often are slightly different, but we will see, again, gross abnormality. Much higher phospholipid concentration. If we're dealing with lupus anticoagulant, that may have an important difference. It's likely the prolongation would be substantially less. If we're dealing with an antibody against factor VIII, we're going to see gross prolongation with any reagent. So we can start to, by looking at the pattern with these 2 reagents, we may be able to draw some conclusions about the test plasmas. Okay. APTT reagent, this is the control. This one also has a 3-minute activation time. Okay. The main cause of differences between APTTs performed with different reagents. The most frequent cause of a big difference, lupus anticoagulant, for the reasons I've mentioned, it's all about the phospholipid concentration. But there is a second, much rarer, rather rare, defect in which we do see quite different APTTs according to the reagent. And that's patients who have pre-kallikrein deficiency. It's a rare event. In my centre, we've seen 2 or 3 over the last 10 years testing 200 patients a day for APTT. So it's a rare event. But it's in the literature, and we noticed also the same. If you make the APTT with most APTT reagents, there is a very gross prolongation of clotting time, 90, 100 seconds maybe, with the exception of reagents in which the activator utilizes ellagic acid. Remember, one of these does. If the activator is ellagic acid, we noticed, and again it's in the literature, that the contact phase runs at a normal rate and the APTT is normal. So we see a gross prolongation with most reagents, but a normal result if the activator is ellagic acid. It's a rare event, but it's the only time we see that pattern not as a consequence of lupus anticoagulant. Just something to keep in mind. Well, the other important point about such patients, pre-kallikrein deficiency, no bleeding tendency. Absolutely no bleeding whatsoever in relation to that behave in a normal way. So the most prolonged APTTs we saw, if you remember, were in number 2, number 3, number 4, a little bit shorter in patient number 1. Control is incubating and we're up to 3 minutes. Just whilst we're incubating these last few APTTs, the other area that's absolutely important to keep in mind for APTT are pre-analytical variables. It's the way the sample is collected and handled has a really important impact on APTT. It's the test amongst clotting tests which is most affected by problems in sample collection and processing. Control time 38, 39. So that's a little shorter than the other reagent. Any problems in collecting the sample, difficult to venipuncture, any delays in blood collected into a syringe prior to mixing with anticoagulant, these can lead to changes in the sample which impact on APTT more than any of the other tests. We can start to get clotting activation in the sample, generates enzymes, and it can mean when we make the APTT, sometimes we're seeing extremely short times because we've got enzymes present. Sometimes we're seeing consumption of clotting factors, and by the time we're making the test, the sample's partially clotted, we've lost some of the clotting factors, and we can see artificial prolongation. In particular, any kind of hemolysis of the sample that's artificial, anything that's occurred during collection and processing, even very minor levels of hemolysis can impact on APTT, causing changes in both directions, sometimes false prolongation, in particular and more frequently, falsely shortened APTTs. And of course that allows really the worst scenario, which is a falsely normal result. If we're using APTT to screen for a possible bleeding disorder and we get a falsely normal result, that could prevent, depends on local protocols, but that could prevent additional investigations that would have been needed. So I think we really don't want to see false normal results, and that can occur in the presence of hemolyzed samples. So in my opinion, it's absolutely essential to have robust checks in place to detect hemolysis and to reject such samples and not to test them for APTT unless we believe the hemolysis has occurred actually in vivo in the patient. It's from time to time, of course, this will occur, transfusion reaction, autoimmune hemolytic anemia, sickle cell crisis, that there are some occasions. But the vast majority of samples arriving in the lab, blue top citrate samples, arriving in the lab with visible hemolysis, vast majority, it's an artifact, it's occurred in the sample, and that sample should not be tested. We will absolutely see an impact on the results, an important impact. The APTT is also particularly sensitive to the ratio of blood to anticoagulant in the tube, the filling of the tube. You know that the normal ratio, 1 part anticoagulant, 9 parts blood. If we deviate from that, and particularly if we reduce the volume of blood, therefore the volume of plasma, change the ratio of citrate to plasma, there are important dilution effects, citrate excess, false prolongation. A similar situation can occur if a patient has an elevated hematocrit, 55 or 0.55 if you prefer, and higher, can start to have an impact on results of APTT. And there is a section in the WFH laboratory manual, a small table that shows how to make an adjustment in this citrate to blood ratio in order to deal with this problem of citrate excess in the presence of raised hematocrits. And I think it's important to do that, particularly if the hematocrit is up around 0.6 or 60 or higher. We see occasionally as high as 0.7 or 70%, depends on your units. Okay, 3 minutes. Calcium. Patient number 1. Okay. Okay, so 39, 40 seconds. This is a different APT reagent, as I mentioned. Has a different reference range. Previous reagent, upper limit of reference range 39. This has an upper limit of reference range of 29. So 39, 40 seconds, prolonged result. First reagent, 47, 48. Upper limit of normal 39, prolonged result. So we've got a pretty similar degree of prolongation in both reagents. This is a patient with mild, we're not doing any more tests, so I'll tell you the answer. This is a patient with mild haemophilia. The level of factor VIII, 30 international units per deciliter. For these two reagents, we're seeing a prolongation. And of course, that's what we want. We want to see a prolongation. We want to detect that abnormality. It's a clinically relevant abnormality. Just whilst we're talking about that, I'm going to start number 2 with the second reagent. We only have a few more tests. Bear with us. So these two reagents, clearly prolonged result, 30 international units per deciliter. Actually, it was 29 in this patient, I remember. These are sensitive reagents in relation to factor VIII deficiency, mild haemophilia. We have guidelines available to us, but there's a lack of consensus really on which is the level of deficiency that we would like to detect. I think everybody has agreed that we want to see an abnormality in an APTT where factor VIII is 30 or less. That's a common feature. But of course, some patients with mild haemophilia, mild von Willebrand's disease, just start the activation. Some patients, 35, 40 units per deciliter, factor VIII. So it's important also to detect these patients. Whilst they may not have day-to-day problems, of course there are important times where they're going to need protection, so we want to know about these levels. And there is some variability between different APTT reagents in their sensitivity to the levels of factor VIII. The really poor reagents that were available many, many years ago have largely disappeared, so the majority of reagents currently available to us will usually give us prolonged APTTs for any levels of factor VIII below 30. In the 30 to 50 area, in that zone, let's say getting up towards the reference range, then there is variability between reagents. So for most reagents, we will sometimes see a normal APTT in the presence of 40, 45 units per deciliter factor VIII. We have to keep that in mind. It's one reason why we can't use a normal APTT to exclude the presence of mild haemophilia or mild von Willebrand's disease. There is another reason. Some mild haemophiliacs have a particular defect in the factor VIII gene, which impacts on the activity of factor VIII in a chromogenic assay or a two-stage clotting assay, but doesn't affect how the factor VIII works during a one-stage assay or in an APTT. So those small subgroup of mild haemophilia patients, normal APTT, normal one-stage factor VIII assay, but do have mild haemophilia, have bleeding symptoms consistent with mild haemophilia, have identifiable, a number have been identified, defects in the factor VIII gene, some of which affect the stability of the factor VIII. Sometimes that's the cause of the difference in the different tests, but nevertheless, these patients do have mild haemophilia, do have bleeding consistent with that, therefore we want to detect them, and they'll be missed by APTT. So we can't use a normal APTT to fully exclude mild haemophilia A. Thinking about mild haemophilia B, it's a feature of pretty well any APTT reagent that it will usually be more sensitive to levels of factor VIII than to levels of factor IX. We know this because if we use those reagents in one-stage factor assays, we can draw some conclusions from the dose-response curve in the factor assays, and they're almost always a steeper slope for one-stage factor VIII than for one-stage factor IX, as an indication of this issue. It means that we will more frequently see normal APTTs in the presence of mild haemophilia B. So in particular, haemophilia B, mild haemophilia B in the 30 to 40 to 50 units per deciliter. For even the very best APTT reagents, some of those patients will have a normal APTT. So once again, we can't use a normal APTT to exclude the presence of such a problem. We should also keep in mind that the APTT is very much affected by the level of factor VIII. So if we have a mild haemophilia B patient who's unwell, sick, acute phase response, marked elevation in factor VIII, 3, 4, 5 times normal, 300, 400, 500 units per deciliter, that compensates during the test. So even though the factor IX is 20, 15 units per deciliter, there could well be a normal APTT as a consequence of this marked elevation in factor VIII. This absolutely occurs from time to time. And the same problem occurs with factor XI. Mild deficiency, masked by acute phase response, high level of factor VIII. So again, we have to be careful not to overinterpret APTT. So this is patient number 2 now, second reagent. Remember with the first reagent, 116, 113 seconds, pretty grossly prolonged. This showed an excellent correction. Reagent number 1, 50-50, normal mix, it corrected to 36. So highly likely to be a deficiency from that. Now with the second reagent, remember it's a different reference range, grossly prolonged. 93 seconds, 91. Oops. Grossly prolonged with both reagents. Suggestive of a pretty marked deficiency. Very good correction, also suggestive of a marked deficiency. This patient has severe haemophilia A. Complete absence, less than 1 international unit per deciliter factor VIII. Essentially no factor VIII. Still clots, I think you know this, but it's a gross prolongation, both with both reagents. Not the same time, but a gross prolongation. And so that's typical of severe haemophilia A, typical of severe haemophilia B. We expect to see gross prolongation, we will see gross prolongation irrespective of reagent. Not the same numbers, that depends on the reagent. Okay, patient number 3. So a number of situations where we can't use normal APTT to exclude mild bleeding disorders. I think it's an important limitation. How common are those kind of defects that I mentioned in relation to mild haemophilia A, normal APTT, despite presence of mild haemophilia A? How common? Well, there are studies from our own centre in Sheffield which suggests about 5 to 10% of subjects who have mild haemophilia A would have this pattern, about 5 to 10%. And that's a very similar occurrence to the data published from some Australian group. They've also described this problem in about 5 to 10% of their patients with undoubted mild haemophilia. So it's not just a UK issue, it occurs in other areas. There are similar reports from other areas, so I'm convinced this is a problem that's prevalent in a number of populations. We don't yet know if it's there in all populations worldwide. This is patient number 3. Remember, this was the patient with 75, 76 seconds, pretty gross prolongation, not as marked as patient number 2, but gross prolongation with the first reagent. First reagent, low phospholipid concentration, silica activator. When we did the correction, 50-50 mix, first reagent, 59, 60 seconds. So still grossly prolonged. So this is the one where we thought we're pretty confident there's an inhibitor present. We're pretty confident this is an immediate acting inhibitor. Made the mix, did the test, still grossly prolonged. A little bit shorter, but some dilution. So consistent with lupus anticoagulant, certainly an immediate acting inhibitor. Now finishing the APTTs with the second reagent. For number 3, 35 seconds. Reagent number 2, remember, this was the very high phospholipid reagent. Upper limit of normal, around 29. This was a patient in which the APTT with the first reagent, 76 seconds. Gross prolongation, very poor correction, 59-60 on the 50-50 mix, immediate acting inhibitor. Now we've got further confirmation. APTT with this second reagent, very high phospholipid, very insensitive to lupus anticoagulant, much less effect because of the high phospholipid, and a result close to normal, 35. Sometimes with this reagent you will get a normal result, sometimes there will be some mild prolongation as there is in this case, but you can see a marked difference. 75, 35, big difference. That's a feature of lupus anticoagulant. So you're not surprised to hear that sample number 3 is from a patient with quite a strong lupus anticoagulant from my centre. It's a sample that we distributed through proficiency testing programs and showed a strong positivity with the specific tests and prolonged APTTs with the vast majority of reagents. Normal APTTs, or close to normal, only those few reagents with very high phospholipid. This is a patient with lupus anticoagulant. This is a typical pattern. Second reagent, sample number 4. APTT, 110 seconds. Gross prolongation. Now just remember sample number 4. And we did this with the first reagent, low phospholipid, 140. Intermediate correction, came back to 46. Not back to normal. Consistent with what could be a time-dependent inhibitor. It's not typical of lupus anticoagulant. Here we are, second reagent, high phospholipid concentration, 110 seconds, gross prolongation. Not lupus anticoagulant. Highly suggestive of a time-dependent inhibitor. Actually, this is a severe haemophiliac, congenital haemophilia, a patient who developed an antibody following replacement therapy. Congenital haemophilia, antibody secondary to therapy. And that's a fairly typical pattern. If we had incubated that mixture in the water bath, 1 hour, 2 hour, we would have seen that 46 seconds increasing 70, 80, 90 seconds over time. That's a classical picture in relation to congenital haemophilia with an antibody. And that's a patient where we would make the specific inhibitor test in order to quantify the antibody. It's important to know the concentration. A few final comments about APTT that we did not yet get a chance to make. Another variation between reagents is in relation to factor 12 deficiency. Factor 12 deficiency not associated with bleeding, relatively common amongst hospital populations, at least mild deficiency. And this can prolong the APTT with some reagents, more than with others. So the detection rate or the number of such samples with prolonged APTT, that also varies a little bit between reagents. If we are a centre who is using APTT for heparin dosage assessment, in addition to bleeding disorder work, and as I mentioned, that's I think very frequently the case for many others, then we really must pay attention to the different heparin sensitivities. It's important to establish a reagent-specific therapeutic range, and there are publications and guidelines which advise us on how to do this. There's a UK guideline from BCSH, and there are international guidelines also on publications. So we have to keep in mind that we will expect to see very different therapeutic ranges according to different APTT reagents. So I think that's also important to keep in mind. We mentioned already pre-calicreína deficiency, high molecular weight kininogen deficiency. We can also see differences between results with different reagents. So we've spent some considerable time discussing APTT. Thank you for your patience. I think we've done that because it's a really important test, and it's absolutely essential that we understand, those of us working with this method, it's absolutely essential that we understand all the detail of the method that we're using. What's its limitations? What will it tell us? What are the likely pattern of results? How to interpret those? And again, I would refer you back to the WFH laboratory manual, where we go into some more detail about this, and there's some important information also contained within this.